for Jackson Hospital and Mosaic Clinically Integrated Network, Dr. Courtland Keteyian. Welcome back.
Hi, thanks.
You have a long title, a lot in your realm. You're heading up occupational health here in Jackson, the Mosaic Clinically Integrated Network. That's for the whole Henry
That's
Ford.
for all of Henry Ford, yeah.
All of Henry Ford.
So occupational medicine is here in Jackson, and in Occ Health we take care of workers, right? So people that get hurt on the job. So and in the Jackson region, there's about like 500 companies we have relationships with that all the way out to Jonesville and Hillsdale, and we're kind of spread around. But then my system role is president of the Clinically Integrated Network, and so that includes really all of the physicians that are affiliated with Henry Ford. A lot of those aren't employed by Henry Ford. They're independent doctors in the community, and we want to be able to all be able to work together. And so in Jackson, about half the doctors in our network are independent in the community. But we've got the Michigan State Medical Group actually is in the network. All of the Henry Ford affiliated medical group docs. There's other independent docs in Southeast Michigan. So it's about 4,500 physicians. So it's one of the largest networks in the state, actually. It's very large.
And from the patient standpoint, we really see the connection, say on a visit. If you sneeze in one office, they know it in the other. And that goes for your lab tests, results, x-rays.
Yeah, that's one of the things that's really nice is that as we've been able to stitch this network together now across kind of most of the southeast and central part of the state, we're all on the same electronic medical record. So you can see, right, if a patient sees me in Jackson and then I order a CT scan, and they end up going to the ER in Detroit, they can still see, right? All that information is shared and available. So it is definitely a much more kind of patient-centric way to do it. We all have the same information.
I heard there's going to be a major upgrade to Epic pretty soon.
Well, Epic is always upgrading, and there are memes about Epic upgrades in the physician community. So it's always evolving and updating, usually for the better. But then there's usually some tweak that we can't understand, and then we have to figure out what that was for. But it's like any software program, like Microsoft or something. It's that they're always updating the software program. With the Henry Ford merger with Ascension, they're now all coming onto Epic as well. So that's actually a really big lift for us, is to start to bring those other hospitals and doctors onto Epic. So but Epic I think now is something like 2/3 of U.S. healthcare. I mean most facilities are on Epic. So I mean something like 300 million people in the United States have an Epic, electronic health record.
And it seems like they also integrate with each other. So if Sparrow or U of M, which they're both Epic, they can connect with our.
It does, yeah. So if somebody has care at U of M or has care at another facility or like Corewell or something where they're on Epic, you can. It's not as seamless, but you can query and find that information and see what's happened. So. We're not at the state of a true, national electronic health record, but Epic as an independent company has almost kind of done that for us.
So we have no Ascension hospitals anywhere near us here in Jackson. So
right.
The combination, the merger, is there going to be any net effect to us from that?
In Jackson, not really. I mean, it's not that we're not building new hospitals in Jackson County or something like. Most of the Ascension footprint that joined Henry Ford is in Southeast Michigan, right? Detroit, Macomb, Oakland County, and so that's really where I think patients will see more continuity, right? Because all those hospitals and doctors will come in, but for folks here, I don't think they'll see a really significant impact from that.
I think there were 4 Ascension hospitals that weren't part of the deal, and I think they just closed, right?
Yeah, I don't know if they closed, but there's certainly, well, there are other Ascension hospitals. There's Ascension hospitals in Kalamazoo. There's some that were up in the northeast part of the state that weren't included in the deal. They got there was Ascension hospitals in like Standish and that they got transferred over to my Michigan, I think is where those landed. But but I don't know that any closed. I think they all transferred to other owners.
All right, winter's back.
Yeah.
Yeah. So, and I think the hope is, that as the temperature warms up, people get outside more, we'll be less exposed to things like the respiratory viruses and other illnesses.
Yep.
But they're still here.
They're still here. And so if you start with the common ones, right, flu and COVID, this was a bad flu season. So about 45 million flu cases. Which is the worst year that we've had since like 2017-18. And so I'm sure a lot of viewers had the flu this year, just statistically speaking. And there was about 25,000 deaths from the flu this year, which is high. That's a high number. So this was a bad flu year. The severity of flu has gone down. So there's less flu activity now than there was last week, and less last week than there was a month ago. COVID's the same. COVID gets tracked now. We're not great about testing for COVID, and the main way that we track it is with wastewater sampling. And you can look for viral genetic material in wastewater, and then get an idea of how much activity there is in a community. So that the COVID level actually now is actually also pretty low. So we seem to have come out on the other end of those in particular.
A lot of people are complaining about the symptoms, and they're really not sure what they are symptoms of. And it sounds like if people go to a provider, you can't even tell, because there are so many different respiratory viruses going around right now.
Yeah, it's really important. It's really, and I've I emphasize this a lot, I think, is that patients will say like, well, I know it's not COVID, I know it's not flu or something, and like, you don't really know unless you get tested. And so, there's no such thing as like, well, it's just a cold. Like, I mean, how do you know? There's really not. I mean, the COVID virus has changed so much from like the initial, 4 years ago, where you would lose your sense of smell, and you like there was sort of a characteristic set of symptoms for that initial wave of COVID. And now it's not necessarily like that. You might just get some aches, right? You might have very mild symptoms or almost no symptoms, and it can still be COVID. And so I think it's been easy to get kind of complacent and not get tested and not use a mask. But I think it's a good rule that if you do have any symptoms and you're around other people, it doesn't matter what the symptoms are, just putting a surgical mask on almost completely eliminates the risk of transmitting to anybody else. So it's just like a nice thing and considerate thing to do for other people. If you're in an environment where you can't just, work from home or, stay out of that space. So the mask is a really, really effective way to just prevent spread to other folks. And it's good to get a test, because you'll know then, like you'll know exactly what it is. And like COVID tests are over the counter now, they're cheap. Like it's a really easy thing to do. So the thing that's truthfully the bigger concern now is measles, and measles is a disease that we had almost completely eradicated, and there's like 400 measles cases active in Texas right now, and we've had 3 measles cases in Michigan so far this year, and so that's one of those ones where it happens more in kids. Because those are the ones who may not be getting vaccinated, and we need to have about 95% of kids vaccinated, like in the kindergarten age group, to have herd immunity, because measles is so contagious. And right now, nationally, those rates are around 93%. So
that's close. But a little difference.
It's close, but that little difference is the difference between herd immunity and having outbreaks in communities where there's hundreds of cases. And and it's actually pretty serious. I mean, people talk about, just kind of let their kids get it or whatever, or having like measles parties and things like that. And it's an incredibly bad idea. Measles causes hospitalization about 20% of the time. And 3 in 1,000 people die. So it's very serious, and it's treated in a way now that I think is like very cavalier because people haven't really had the experience.
We haven't heard about it for like 30 years.
I mean, we essentially eradicated the disease entirely through through the magic of vaccines, and so because vaccine hesitancy has increased, really in a response to COVID, right? There's been an uptick in skepticism on vaccines during and post-COVID. It's translated to lower vaccination rates, which is killing children. And it's not the issue is that there are age groups of children that aren't old enough to get vaccinated yet. And so the reason you need herd immunity in the kids that are old enough is to create that kind of like protective bubble around younger children. And so it is in my opinion, incredibly irresponsible not to vaccinate children, because there are other kids who cannot be vaccinated, who have no protection, and they're the ones that are being placed at risk when those decisions are made to not vaccinate kids that are older. So the second measles vaccine is given once kids hit 4 years old. So you got to be at least 1 for the first and then 4 for the second. And so you can't vaccinate kids that are infants in the first year of life. So they're completely exposed. And if they're around other kids that are not vaccinated and they get it, that's a really bad situation.
So we're hearing about outbreaks in certain parts of the country, like Texas.
Yeah.
And apparently a couple of the deaths of children in Texas have been in religious communities, the Mennonites,
Mm-hmm.
which is apparently a community that does not vaccinate their kids.
Mm-hmm.
So that would be, groups like that would be in that 5%, above 95%, that would be protected if we had a compliance of 95%.
If the rest of us were vaccinated, then there wouldn't be a reservoir that could essentially transmit, right? And we'd have herd immunity. But because now we're only vaccinating 93%, and measles is so contagious, that you need a lower percentage if it's less contagious. Measles is the most contagious disease that we know of, right? So the sort of case study where they initially, I shouldn't say initially, but where I think really understood how contagious measles was. I think it was the early 90s. There was a Special Olympics where there was cases of measles, and they were able to trace transmission to people that were 100 feet away from cases.
Wow.
Like outdoors in the stands at the Special Olympics, and people 100 feet away got measles. So, I mean, think about that, right? We talk about 6 feet social distancing with COVID. This is 100 feet away outside, and people got measles. So
That's amazing.
It's incredibly easy to spread. And so to be unvaccinated is really sort of rolling the dice.
All right. Protect your kids and your family. If they're not vaccinated, they should be. So we saw the hospital filled up with respiratory issues. What about the ER? How are we doing in the ER?
So the ER is pretty much always busy, no matter what we do, which is interesting. So we look at, so as this network, right, across kind of all of Southeast Michigan now, we look at for the thousands of providers and hundreds of thousands of people, kind of patterns of use, right? So do people go to urgent care? Do they go to their primary doctor? Do they go to the ER? What kind of conditions do they go for? And what we found, if I'm just talking about Jackson, is if we look over time, over the last 10 years, we've seen fewer visits to the ER, which is what we want to see, right? Like nobody's having a good day if they're going to the hospital, so I don't think. And so we've seen the total numbers of visits go down almost 20% in about 10 years. which is great. That's exactly what we want to see happen. But what's interesting is the people who do go to the ER, the severity of their conditions are lower. So you would think that we'd be like getting rid of those kind of low acuity, like, you know, back pain, fever, sore throat, you know, runny nose, you know, like urinary tract infections. A lot of those things go to the ER, and you would think, okay, so if the volume of visits is going down, it's those lower acuity ones that don't really need a hospital that aren't coming.
When I go to the ER, I look around and I think, well, you don't look that bad.
Yeah. And so that's exactly what's happened. And so what's sort of the opposite of what we would expect is it's the higher acuity, it's the sicker people that it seems like we've done a better job over time managing within primary care and managing at home. But the actual number, not just the percent, but the number of people who are less sick going to the ER has gone up, which was very counterintuitive. And so we're trying to understand why that's the case, why there are people that are less sick going to the ER. So I think it's worth mentioning, like, you know, we work very hard in the network, in the community, that primary care doctors have same day availability, right? So that if you're sick and need to be seen same day or even next day, right, they can get you in within 24, 48 hours.
Plus IEP and
there are urgent cares all over the place, right? There's IEP on Michigan Ave. They're putting in another one on the other side of town, right? I mean, there's lots of opportunities to get care that doesn't have to go to the ER between urgent care and primary care. And so it's really interesting to see that the type of level of visit that typically would go to an urgent care or a walk-in clinic seems to be going to the ER more often. So I think we have more understanding to do there, but I think it's worth noting for everybody, right, people who are watching, that a lot of the types of things that folks may think they need to go to the hospital for, a phone call to your primary care doctor or a visit to the urgent care, I mean, if they can't take care of you, they're going to send you to the hospital, right? Like no urgent care wants somebody that you know is arresting with chest pain, right? Like that's not going to be managed well in an urgent care. But there's a lot of things, you know, strains and sprains, orthopedic type things, right? Urgent care is an easier place. You know, runny nose, congestion, those types of things, low back pain. I mean, a lot of these conditions are treated better and faster just outside of the hospital.
Do your own common sense triage before you...
Yeah. And of course, I mean, I'm not saying, right, like, you know, people come to the hospital, they're going to get care, right? Like that's not the message people should hear, right? It's just an interesting feature of the data. Like we would have expected the opposite result. And so now we're trying to understand, given that we've increased the capacity in the community to take care of these lower acuity type conditions, how come more of them are actually going to the hospital? So there's something happening there we don't understand yet.
But in every event, you have chest pains or stroke symptoms, there are certain things that you...
You got to go to the hospital, yeah. I mean, that's what the hospital's for, right? That's, if you have a runny nose and a fever, right, you know, we can take care of you somewhere else and it'll be faster and you'll get better attention. And that's no criticism of the ER, but, you know, they're busy with the chest pains and the strokes and the serious things that have to go to the hospital.
Makes sense. As always, we appreciate all the information you bring. Thanks for coming in today.
Thank you.
From Henry Ford Health and Henry Ford Jackson Hospital and Mosaic Clinically Integrated Network, Dr. Courtland Keteyian.